Okay. Good. Please, can you hear me now? Let me hear from you. Okay. Can you hear me now? Is it better? Is it better? Let me know if you can hear me from your end. Okay. Don't rely on someone's answer. I want to know whether you hear me so that we start. Okay. Perfect. Let me know if you can hear me. Good. 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 Right. So let's start. So today we are doing pediatric advanced life support. Pediatric advanced life support. Okay. Right. So let me share the screens. Let me start from there. Pediatric advanced life support. Okay. Pediatric advanced life support. So we are going to, I've got answer scenarios for you and questions, and I've got this one too for you, the seminar. Okay. We ideally every day we spend 2 to 3 hours on the line. Okay. We don't go past 3 hours. So we let's start. Okay. Let's start. Okay. So pediatric advanced life support. Pediatric advanced life support. Pediatric. If the font size is too small, let me know. Okay. If the font size is too small, let me know. My name is Paul Wright. I'm a registered nurse. So today, by the end of everything, anytime a child is brought to your care, okay, as a nurse, as a healthcare professional, you should be able to know what is wrong with this child, how sick, is it sicker, sickest, okay, how sick is this child, the severity or the intensity of the sickness, okay, what should I do first and what should I do next? And after everything, you ask yourself, did my interventions work or not? Did it work or not? Okay. Yeah. So this is what we are going to look at. So this is a master course map. So we are going to, I'm teaching you on 12 topics. Okay. So we are going to look at the systematic approach and for and also the pediatric assessment. We call the PALS, the Pediatric Advanced Life Support. Okay. So we will look at the respiratory distress and the difference between a child who is having respiratory distress and the different and respiratory failure. Okay, so now let me ask you this question. Show me your answer. When we say a child, the developmental milestone, when we say a child, it starts from which age to which age, or it ends at which age? Yes, let me know in the chat box. Who is a child? At what age are we cutting it? Yes, who is a child? Send me your answers. Yes, I'm waiting for you. Send me your answers. Okay, who is a child? Yes, a child. A child is what age? I want to know. Let me know. Okay, send your answers. Who is a child? At what age are we looking at when we say you are dealing with children? Who is a child? 0 to 12. Yes, another person. Okay, pediatric. When we are looking at pediatric, okay, what age are we looking at? Or who is a pediatric? Yeah, some are saying 16, 1 to 18. Okay. Some are saying 0 to 16. Yes, let me know who is a pediatric. Good. So we will look at a pediatric has come to you. Okay. What is, he has come with a respiratory condition. Is it distress or failure? We look at those things. Okay. What is, when can we say this respiratory condition is a upper airway? Okay. Or is an airway condition? Yes. Is it upper airway or lower airway? Okay. Then we also look at shock and management, the pediatric bradycardia, the pediatric tachyarrhythmias, pediatric cardiac arrest. Then we have the BLS, okay, CPR, the AED and foreign bodies. Then neurological, toxological, and special pediatric emergencies. We look at the post-cardiac arrest, okay, then the pulse mega code and scenarios. So that's what we are going to look at, okay, right. So let's start. I'm not going to waste your time here. Let's start. What is pulse? When we say pulse, it's an acronym. It says Pediatric Advanced Life Support. But this pulse is designed to recognize and manage critically ill infants and children. Okay, to manage critically ill infants and children. Okay, so the key concept is to recognize deterioration before cardiac arrest occurs. Okay, before cardiac arrest occurs. And I've told you that when we say cardiac arrest, we are looking at the cardiopulmonary. Okay, so the heart and the respiratory system. So the heart failure, okay, or the cardiac failure and or the respiratory failure. These are the two things we are looking at. Okay, so pediatric cardiac arrest mostly follows progressive respiratory or circulatory arrest. It's very difficult for you to know that a child is walking and he fell, cardiac arrest. Okay, most children who are brought to the hospital, they end up having cardiac arrest when they either have a respiratory arrest or a circulatory failure. Okay, yes, that will end. That it's not like adults that it will start from cardiac arrest before the respiratory. No, children start from the other systems and they fail with the heart. Okay, so when a child is presented with or when you are presented with a scenario like this, don't immediately start looking for drug. Don't immediately start looking for drug. I want amiodarone. I want this. I want medication that will start the heart. No, I want a epinephrine or adrenaline. No, there are some questions you have to ask yourself. That is why you and I today we are here. So the first question is, what physiological system is failing? Is it the heart? Is it the respiratory system? Is it the circulatory system? Is it the brain, the nervous system? Is it the cardiovascular system? Okay. So always think about when you get children, respiratory, circulatory, neurological, or cardiac. Okay. Think about it. So until you ask yourself this question, it will be very difficult to treat the child well. You can treat the child, but it will be difficult to treat the child well. Okay. Now let's look at the formula. So the PAUS is it is an internationally. I'm not only teaching you because I want to sat at one corner and I've drafted this. No, this is an internationally recognized formula to teach on how people should attend to, okay, or approach PALS scenarios. So when we say PALS, pediatric advanced life support, we have a formula, and the formula says which is approved by WHO. You look at the child appearance, you listen. Is there anything that you can listen to? The way they are breathing. What are the things we can listen to? They are breathing. Is there any sound with it? Is there any stridor? Is there any wheezing? Is there any crackles? Okay, there are heart sounds. Are you hearing any abnormal heart sounds? Okay, so all these ones, abdominal sounds. Okay, are you hearing it? Then you assess until you look and you listen. You can't assess. You assess the child. So after your assessment, you now classify the intensity of the disease. Is it sick? Is the child sick, sicker, or sickest? Because especially those who are the OPD, children whom their parents bring to the OPD, some of them will be playing, some of them will be jumping. Some it doesn't mean they are not sick; they are sick. But until you look at them, until you listen, until you assess, you will know this child is a sick child or a sicker or a sickest. That's it. So until you know this, it will help you to intervene and also to reassess whether your intervention worked or not. So every scenario should be approached in this sequence. Write it down. Every scenario. So you look, you listen, you assess, classify, intervene, then you reassess. That's it. Okay. Right. Let's look at an example. A child, 2 years old child, brought by the mother to the hospital. He is having a barking cough. You assess the stridor when the child is crying. The baby is alert. Okay. Saturation is 95. So when you are approaching this child, when you are approaching this scenario, this somebody's child, when you are approaching, don't immediately think about, I'm going to give what? Dexamethasone. No. Okay, I'm going to think about this. No. You look at what? You first think about this algorithm. Look, listen, assess, classify, intervene, and reassess. That is the pause. Okay, so let's link it up. Airway. What am I hearing? Okay, you have looked at the child. Yes. What am I hearing? Am I hearing any sound? Am I listening any sound? Yes. Upper airway obstruction, because the child is having what? Stridor, barking coughs. Okay. Okay. You look at the child is alert. He's playing, he's jumping, he's doing everything. That is your look. Now you listen. You listen, you heard what? You heard stridor. Anytime the child is crying, he's having stridor. When he stops crying, the stridor goes. Okay. When he's coughing, he's barking. You are hearing barking cough. Okay. That is the what? Look, the listening. Okay. Then that should tell you that this is a coup. Okay. And so you've made what? You've assessed here. You know, you classify this group. Is the yes, the child is distressed. The child is currently stable. I will explain this to you. Stridor when child is crying and stridor when child is sleeping. When we get there, you understand it. Okay. Yes, it is something that when you practice it a lot, you know. Then you treat. Okay, you treat. So that reasoning prevents mistakes when the scenario changes. Okay, it prevents mistakes when the child. So those of you who work in pediatric units, when you go back to work, do you reassess? Yes, you admitted the patient yesterday. You did your assessment as a nurse. You went home. You came back. Ah, this one I know him already. I know this family already, so I don't need to reassess. No, you need to reassess to help when scenario changes. That's it. Okay. So this is the world what this is the world's pediatric assessment triangle. Okay. Pediatric. Every child that goes to the hospital, clinic, comes to church, wherever, who is sick, comes into your care, okay, is having these three issues. Until you know this, don't go ahead to treat the rest. Okay. So always start with the A. Don't start with the C. Don't start when we are counting A, B, C. We start with A. So appearance, look. So what is the look? How is the child looking? How is the child appearing to you? Is he alert? Is the child interacting or lying down quietly? Okay. You are looking at the child from head to toe. You are looking at the child. The child is on the mom. The child is on the stretcher. There's whatever. The child is twitching. Okay. The child is crying. You are looking at the child. The child, the muscle tone, are they normal? Okay. You look at the child. Are they ill or irritable? Is the child calm or anxious? So this goes under what? Appearance. What does the child look like? Okay. Then when you are done with this, I've told you that before a child will have cardiac arrest, it will either start from what? The respiratory system or the circulatory system. Yes. But when we are doing our AMASA, when we are doing our priority, we don't jump to circulation while breathing is there. Okay. You understand? So you go to breathing. You have done the appearance. Go to breathing. So breathing, how is the child breathing? That is your first question. The next one, how fast is the breathing? That will help you with the rate. Are they above 20, 30? Are they in their 40s? Okay. Yes, now you know it. Are they using the normal muscles of respiration or what? Children breathe from stomach up. When children are using their muscles to breathe, they use most of the abdominal muscles to breathe out. Okay, in and out, abdominal. So if you look at these small kids, their belly is a bit protruded. When they are breathing, then the belly will be moving up and down. Unlike we adults, we use most of our intercostal muscles, the diaphragm, and all those stuffs. Yes. Okay. So are they labored? Are they having labored respiration or not? Okay. You listen for abnormal sounds. So you hear crackles, you hear stridor, you hear wheezing, you hear ronchi, all those things. Okay, you hear. Then you look for retractions and nasal flarings, grunting and head bubbling. All these ones should tell you that no, this breathing system is having a problem or not. Then from there you go to circulation. So circulation, let me drag it here a little. So circulation, you look at how are they circulating. Don't start looking at are they bleeding, are they this. No, look at the skin. What is the skin color? Are they pale, mottled, or cyanotic? Are the lips or nail beds pink? Is it central cyanosis or peripheral cyanosis? Okay. Circulation, blood is warm, skin will be warm. So is the skin warm or cold? That should help you with what? Issues. Okay. So the pediatric assessment triangle helps you identify children who may need immediate intervention. If any part of the triangle looks abnormal, act and reassess it. So after you've done your triangle, always ABC, 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 appearance, breathing, circulation. appearance, breathing, circulation. Appearance. So you look, listen, act, and reassess. That's it. Okay. If you know this, you are done with pediatric and work in pediatric units. Okay. You should, if today you will not listen to anything, not this one. If you not catch anything, not this one. Okay. So the pediatric triangle, right? So always remember your ABCs. ABCs. The A here means what? Appearance. So we've done all these ones. Child is alert. Child is interacting. Are they using their muscles well, of respiration well? Is the airway clear? Okay. All this one. Is the child consolable? Is the child speaking or crying normally? Okay. A child who is playful despite respiratory symptoms is very different from one who is limp and what? Unresponsive. So if you are doing your tracking, if you go and they tell you select one patient that you look for or you look at first, you know which one to go for because you know this now for pediatrics. Bring your mind, take your mind from adults and come to pediatric. We are doing pediatric today. Okay. Yes, pediatric emergencies. Now let's look at the breathing. So you look and listen. Retractions, are there retractions? Are there nasal flarings in children? And how is their head? That are they using tripod positioning for breathing, especially those teenagers? Okay, 10, 12, they can sit. 6 years, okay, they can sit. Abdominal breathing or paradoxical breathing. Okay, so you listen for stridor who is in granting snoring. Snoring is a respiratory issue, okay, unless proven otherwise. Are they gargling? Are they diminished breath sound? Or are they absent breath sound? So all this, look, listen, look, listen, look, listen, look, listen. Don't forget to look, listen, okay. Circulation, circulation, you look for what? Pallor, mottle, or mottling, cyanosis, abdominal, abnormal skin color. Okay, yes. So the part can what? Rapidly tell you, or this assessment can rapidly tell you that what? The child is sick or not. Okay, the child is sick or not. Okay, so now we have done we have looked, we have done our assessment. Okay, or we have looked and listened. Now let's look at the number 4 assessment. Okay, or the number 4. So when you are done with everything, you now come down and ask yourself, it's time for me to treat this child. Okay. The first 2 we did was to help you to know which one to treat first, which one to see first. Okay. Yes. So you have done this one, you know the one you to see first for pediatrics. Now do assessment. You now know the one. Let's say you got 4 patients, 1, 2, 3, 4. Number 4 is the sickest. I want to take care of this child. Okay. So you start with your A, B, C, D, D. Again, assessment, nurses, pediatrics, you have no option. Assessment, this is it. That's it. Write it down, pediatric unit. Okay. You look, you listen, you try, you know which one to see first. So after you've picked the one to see first, you are now coming to gather your data. Okay, so you use the ABCDE algorithm. This is an internationally recognized pattern. Don't sway from it, otherwise you know what to do. The ER nurses, the OPD nurses, the pediatric nurses, all these one, oncology, pediatrics, all these one, you should know. When you know this, you apply it in every situation, pediatric situation you find yourself in. You look, listen, you track, then you use your assessment A, B, C, D. If you don't know assessment, you can't treat. Okay, so your so A, B, C, D. Is the airway open or maintainable? Is the airway open or maintainable? Yes. When we say somebody's airway is maintainable, Somebody, there are some people, their airway is is closed or closed a little, but we can intubate, we can put a trachea, we can do a cryo, puncture it. Okay, we can do a cryo and for the person to breathe. Okay, but there are some people you can't even intubate. Okay, yes, it's difficult maintenance, difficult airway. We call it difficult airway. Somebody has plenty neck muscles. When you tell them to open their mouth, you can't see the back, you can't see the uvula and the palatine tonsils. This is a difficult airway. It is a difficult, maintainable airway. That's it. So children will come, people will come with tonsillotomy, all these ones. Okay. You want to manage the airway. Is it open or is maintainable? So when you are assessing, you look and listen. The same look and listen, oh, these two English. You look and listen. You look, you listen. You look, you listen. When you gather your data, then you manage. So you look at the airway. When the babies are crying, you look at it. When they are talking speech, you look at it. Okay, is there stridor? Are they snoring? You're listening. Are they snoring? Are they giggling sound? Are they drooling? Is there any foreign body? Children, toddlers, they take round objects. They swallow. Airway is very small. Okay, airway is blocked. Okay, secretions. Are there secretions? Okay, example, somebody is drooling a lot with what? Epiglottitis. With stridor all over. Okay, yes. So if, remember, take note of this, children mostly snore. Okay, children who snore has what? Airway problem, unless proven otherwise. That's it. Okay, so when there is a loss of pharyngeal muscle tone, it can allow the tongue and muscles tissues to obstruct the airway. So when the child is sleeping, they are snoring. That's it. Okay, pharyngeal muscle tone. Okay, so all these ones are. Now let's look at the airway sounds. We are still under airway A. Okay, when you hear stridor, it means this is an upper airway obstruction. When you hear wheezing, you are going low. This one we did it in the adult, so you know it already. Wheezing and stridor, they are the same sound, but one you hear it at the upper, one you hear it at the lower respiration. Okay, yes. Then grunting, oh sorry, crackles. So crackle is what? Lung tissue, pneumonia, aspiration pneumonia. Okay, there is a fluid and blood down there, crackles. Okay, so you hear all these crackling sounds. That should tell you that the lung tissues are having a problem, diseased. Okay, they are diseased. So, example, this is the airway, this is the lung. Okay, this is the lung, this is the lung, and this is the airway. The airways connect to the lung. When the airways, they are coming straight from your mouth and your nose. Okay, straight from your mouth and your nose. So when they get here, they divide into two. One will pass right, one will pass left. Okay, they are coming straight to your mouth and nose. So this is your airway. Okay, and these are the lung tissues. So when you hear crackles, it's not a problem of the airway, it's a problem of the lungs. Okay, when I hear wheezing, wheezing is not a problem of the lungs, it's a problem of the airway, but the lower aspect, the bronchioles. At the top here are the upper airways. So I will hear what? Stridor. Stridor is not a problem of the lungs. Yes, you do stethoscope. Okay, but you hear stridor. That's not a problem of the lungs. It's a problem of the airway. So when I block this airway here, when I block it here, I have a problem with air coming in and coming out. So it will come back and affect the lungs. Okay. Somebody is having pulmonary congestions like pulmonary edema, the blood, those blood that are surrounding around the exchanging gases here. Blood, this is a blood vessel. A lot of fluid has moved from here to here. Here is not part of the airway. So when you auscultate, you hear crackles. It means the lung tissues are having troubles. Yes. So somebody will be having granting severe respiratory compromise or lung tissues. Okay. Somebody is snoring. Snoring is not a lung problem. It's an upper airway obstruction, like the pharynx and okay, pharyngeal issues. Gargling, fluid and secretions. Okay. Then silent chest. Silent chest. Silent chest means, let's say this one is totally blocked. Okay. The air is not moving and nothing is coming back. Okay. It has, so over here, I will not hear any sound. How about this place too? The alveoli that are here will begin to collapse. When they collapse, I will not hear any sound. Okay, so your lungs will be what? Silent. You do your stethoscope. Yes, you hear a silent chest. Yeah, when you look, this patient, when you look, the respiratory muscles are working nicely. Okay, so the person is breathing in, out, in. How about the rate? The rate is fine, moving fast. Okay, but you listen, you can't hear any sound. Okay, yes, so these are the things you should know. Now, it says what? Where is it? One of the most dangerous mistakes we do is to think that wheezing stopped. The child is wheezing. You've done your assessment. You hear that, oh, wheezing has stopped. Therefore, this patient with asthma, the asthma has improved. Let us stop. You go and meet them dead in bed. It's not necessary. If the child still has severe respiratory effort, respiratory muscles using it, but has minimal air movement through the airways, that quiet stethoscope sound you are hearing, you are not hearing any sound, may indicate worsening obstruction and impending respiratory failure. Okay, yes. So these are the things you should know. Now let's look at breathing. Breathing before somebody breathes. Today I'm moving fast a bit. Before somebody breathes, they need their nerves. They need their nerves. They need their muscles. They need their bones. That's it. Okay. Yes. Before you breathe, before you can breathe, you need your nerve, the nerves. You need your muscles, respiratory muscles, and you need what? Bones. Okay, the intercostal muscle bones. So we have the nerves. This is the lungs. These are the lungs. This is the airway. Now we know the difference now. Okay, we have the airway. We have some nerves that connect from the brain to here. Okay, to help you to breathe. Then over here too, we have what? Bones connecting. If you look at your ribs, bones, okay, that help. It moves up and down, moves up and down. Then, so these ones help you to breathe. Then the muscles, the intercostal muscle in between these bones, we have muscles like this in the columnar fashion. Okay, like this. We call the intercostal. And below this, there is another muscle here called the diaphragm. And below the diaphragm, there is abdominal muscles. So for adults, don't use abdominal muscles a lot. But children use abdominal muscles and the diaphragm a lot because they have weak bones, weak intercostal muscles. Okay. That is why when you are doing CPR for children, don't go and put all your pressure. on these bones and their muscles. No. Okay, you go and break this bone or you destroy the muscles. So sometimes just one finger or hand encircling the two thumbs will be doing it. Okay, yes. So these are the things you should know. So now let's assess when the nerve tears or when the nerve destroys, breathing will be affected. When muscles tear, any of these muscles tear or get damaged, breathing will be affected. When any of the bones break or they have issues, infection, breathing will be affected. Okay, so all these things you look, then you what listen, you look at the breathing pattern, you look at the breathing, the IPPA, inspection, palpation, auscultation, and what. Yeah. So that is it. Okay. So with breathing, you look at the rate. Okay. You look at what is it the rate? Is it too fast or too slow? What is the normal respiratory rate for children? Sharp. Yes, somebody should type normal respiratory rate for children. Type it. Let me know your answer. Shoot your answers because you should know vital signs for children. Yes, shoot normal respiratory rate for children. Normal respiratory rate. Yes, I need your answers. Shoot 30 to 60. Wow, 30 to 60. Yes, it depends the age. Yes, yes, normal respiratory rate 20 to 24. Yes, shoot. Okay, good. So children, adults will be up to like say 24, 20, 21, 22 below. Okay. So when you see them having a child is having respiratory rates in a space of 1 minute, they are having 16 counts. 16 counts is very low. Okay, they will build CO2 and stop their heart. So that's what. So are their respiratory rate? Is it fast? Is it slow? Or there is no rate at all? Okay. So this is what your assessment. Now the effort, you look at it. While they are breathing in and out, are there retractions? Okay. Are there bone has broken, muscles is torn, that part will be retracting. It moves inside. So while this side is moving up, this side will be moving low. Okay, retractions, it retracts. You see the muscle, the skin pulling inside. Nasal flaring, this flare, the nasal and anterior nerves, not the posterior nerve. The anterior part is moving up, closing and opening, nasal flaring. Okay. Accessory muscles of respiration, the sternocleidomastoid muscles. I mean, they are coming into using it. Yes, their work of breathing has increased. Head bubbling and grunting. Okay. Now, air movement, are they equal? That is where your stethoscope comes in. Are they equal bilateral air movement? Okay. Is it decreased in one side? Is it absent in one? If you cannot hear, you call your friend or your colleague to come and listen, or an experienced person to come and listen. Are there wheezing? Are there crackles? Still under breathing, let's look at oxygen. Okay. SpO2, skin, lips, the mentation. Is plenty oxygen going to the brain or not? Or they are low perfusion. Okay. That should tell you that the brain is in trouble, it's not getting a lot of oxygen for it to work. So their mental status will to be affected. Yes. So it helps you with your. Let's look at pediatrics. What is the difference between respiratory distress and respiratory failure? Well, you see nurses writing nurses notes. Pediatric patient is in respiratory distress. Patient is having respiratory failure. Okay. Adult, when we say an adult is having respiratory failure, we have its own what classifications and definitions. Pediatric, we have pediatric respiratory distress versus failure. Okay, so this is one of the most important distinctions in PAOS. Okay, when we say a child is having respiratory distress, this child is still compensating. Yes, you see them, they are breathing, they are using their muscles, just that they are struggling. Your child in the home, okay, they don't have any issues. Okay, your child in the house, they don't have any issues. But when your child is sick, maybe you have cold, flu, all those things, respiratory distress. Yes, they are breathing fast, they are using their muscles and all those stuff. So you may see things like tachypnea, tachycardia, you see retractions. Yes, they are still trying to breathe. You see nasal flaring. The child is in distress. The child is anxious, agitated, increased work of breathing. All these ones is not you can't say that this child is having failure, respiratory failure. No. Okay. The child is still fighting. That is the basics. The child is still fighting. Now let's look at failure. What is failure? Compensation. That effort is dying out, it's failing. So is their brain affected? Is their brain affected? Ayaraga is going to look at children at the OPD. He went. One of them, the child is difficult to arouse. Other children too are playing, doing everything. You should know, he should know that what this child is having oxygen is not moving a lot to the brain. Something is happening. Okay. So let me try this patient first. So Ayaga will bring this patient to the nurse's station and I'll do the ABCDE assessment and continue care from there. Okay. Poor respiratory effort. Okay. Yes. Poor. They are, you can see that yes, they are tired, they are fatigued, they can't even breathe again. The muscles of respiration is so tired. That is what kills children a lot. And most children who come to they will bring their parents will bring them to hospital for what? Cardiac arrest issues. Majority of them they start from respiratory or circulatory. The child will struggle, do whatever they can do to survive, but with time they will get tired. Their respiratory muscles will be tired, so they will give up. Okay, poor respiratory effort. Bradypnea, that's why you should know your vital signs. Okay, for children. Apnea, cyanotic, central cyanosis, their mouth, their chest, they are all turned blue. Severe hypoxemia, bradycardia, pediatric bradycardia is a very severe issue. Okay. Poor air movement, they are building CO2, acidosis is coming in, then they are exhausted. Yes. So I've got a memory for you. You if you look at the child, everybody knows children breathe fast. Okay, not super fast, but their rate is fast. Look with the rate you people sent me, it's a fast rate. Okay, but you look at, are they breathing slow or are the breathing stopped? If it has stopped, they are exhausted. They are going to get cardiac arrest in the next moment if you don't intervene. Are they slow? They are on their way. Okay, they are still compensating. They are trying their best, but if you don't do anything about it, it will stop. So the child will breathe fast, slow, and eventually stop. Okay, therefore, a falling respiratory rate in a very sick child is not necessarily an improvement. Okay, never deceive yourself that this is an improvement. No, this child will die. Okay, right. So, all these things that I'm teaching you today, you're gonna apply this to your scenarios. I don't know which condition you are going to see the next moment. Okay. Is the child, remember the child with epilepsy. A child will come with epilepsy. They are limping, they are unresponsive, respiration rate is very low. irregular breathing. Some of them will be snoring. Some of them will be having copious secretion. Uh, you can get one child who is limping unresponsive, having epilepsy. Okay, it's not their fault; they were born with it. Irregular breathing, snoring at the same time, copious secretion. Okay, after epilepsy, while they are in their refractory period, some of them will be sleeping and snoring. That's the upper respiratory issue. Okay, you position them well, or you give some oxygens. Okay, saturation, you checked SpO2 74, a lot of secretion from their mouth. Cyanosis, you check their heart rate, it is 56. So what are you going to do? This child is simply not experiencing ordinary respiratory distress. So you will not say this child is having distress. Look at the rate. Look at the brain involvement, unresponsive child. Okay, look at where the saturation is, and look at the central cyanosis, and look at the heart rate. This is a failure. Okay, so these findings indicate respiratory compromise or failure. So, physiology with disordered control of breathing. This is another diagnosis that I'll teach you as we move on. Yes. So somebody is having disordered control of breathing, plus inability to maintain the airway with the snoring and all those stuffs. So this is the problem of what? Airway patency problem and breathing or ventilation problem. Okay. Once you start building CO2, your brain will shut off. So how are you going to treat this child? You've done all this assessment, you know what to do now. That I'm going to prioritize airway, I'm going to prioritize ventilation. Okay, so what are we going to do? Effective bag valves ventilation. So I'm ping, ping, ping. Okay, you push in the air, push in the air. Okay, you are solving that one. Respiratory rate, you realize that majority of these children, when you help their ventilation and their airways, their heart rate will be shooting up. That should tell you, when you start seeing this, the heart rate is moving up. That should tell you that the heart rate that was dropping, the heart that was stopping, was not a problem of heart disease. Children don't have heart disease a lot, unless those with congenital heart disease. Okay, unlike adults who have a lot of heart problems that they will be walking in town and they will suddenly collapse. Children don't have those problems. Okay, so when you see a child's heart rate dropping, that should tell you that the problem is coming from somewhere. The heart has done whatever it can do. It is not being able to do so. They are giving up. Okay. So why is it increasing? Because the bradycardia you saw was primarily hypoxia related. So that is exactly why PALS emphasizes ventilation in pediatric what? Deterioration. Okay. So American Heart Association, when you come here, you do this. You need to get a certificate in this, cardiac arrest and PALS and BLS. Until you get their certificate, you can't practice in any hospital in US. Okay, so as a nurse, so American Heart Association says that what an infant or a child with a heart rate less than 60 per minute with cardiac and pulmonary compromise, despite you are giving ventilation, ambubag, or whatever you intubate, you are giving oxygen, CPR. So whilst you are doing all these interventions, if the heart rate is still dropping and it goes below 60, start what? Your CPR. Help the heart to pump. CPR. That's it. Now let's go to circulation. So we have come to the heart and the blood vessels. So what is the rate of the heart? Is it too fast or slow? Is it absent? Okay, send me. What is the normal heart rate of children, pediatrics? Yes, answer to the chat box. Sharp. The normal heart rate. you know what you are doing, so that we are here to teach and to help each other. Yes, a normal heart rate of pediatrics. You know it too. Yes, I'm waiting for your answers. The normal heart rate. The normal heart rate. Some say 100, 60 to 100. For pediatrics, 60 to, yes, somebody is saying 60 to 100. Others, yes, yes. 60 to 100 is for adults. Okay. Adult like you and I, 110 to 160. Cool. Yes. Sheets. 110 to 150. Yes. So more answers. 100 to 160, 110 to 160. Yes. 100 to 160. Good. So when we are interacting, interact some, okay, so that you remember. Don't only watch what people are posting. So you remember, that day we were doing this and I typed this. Okay, I sent this, I said this. Okay, that will make you remember. That's how the brain remembers things, memory and emotions. Okay, so with this range you have given me, so the normal heart rate is not 100 to 60 to 100. Okay, that is for adults. Okay, pediatrics sometimes 150, 160. Okay, cool, 110, 100. Cool. So, is it going fast? Is it slow or absent? You check the pulses. So, let me take my pencil. This is my heart. This is the heart of a baby or a child, pediatric. This heart has what? Blood vessels connected to it. Some goes to the legs, some goes to the hands. Okay, some go to the head like this. Some will go to the other, yes. So you check your central pulse, your heart rate. That's what we call the heart rate, the central pulse. Okay, we did your apartment, apartment M. Okay, yes. So we did those ones. You know where to do your stethoscopes. You know where to do your heart rate with your stethoscope. Or if you don't want stress, connect this baby to have monitor. It will give you heart rate. Okay, but that is a machine. It can deceive you. Okay, so you check your heart rate here. This is the heart, this circle here. We don't check pulse here. We check heart rate here. When the heart beep, boom, it sends blood away from the heart. So if I come and stand here and this sound here, I palpate one of the arteries here against a bone. Let's say there is a bone here, and I press this artery against this bone, and the heart beat. When I feel it here, I count. That is my pulse. Okay, good. That's my pulse. So you check. Okay, when the heart beat, this one I should feel it here. You check. Somebody's heart beat, boom. It took about 10 seconds before you felt a pulse. That is a problem. There is something that is blocking the blood from coming here. Okay. So you should know all these differences. You should know all these differences. Okay. So the central pulse, the peripheral pulses, okay. Then the strength and the symmetry. So I felt a pulse here. Did I feel a pulse here? Yes, bilateral. I felt a pulse in the left leg. Did I felt it in the right leg? Yes, symmetrical. Okay, good. I felt a pulse around the major vessels. So here, the central pulse, the carotid pulse, these are central. Okay, those blood vessels around this place for central. All those ones far away, somebody will come and check somebody's pulse on the foot, the top of the foot, pedal. This is a peripheral pulse or the radial pulse. Okay, all those ones. Okay, so all these ones you should know and help you to learn and catch it well. Okay, cool. Let's continue. So you know the rate, you know how fast, whether it's slow or fast. Okay, cap refill, we know it already. It ensures your peripheral heart perfusion. Your blood pressure, take note of this. Hypotension is often a late sign, not even often, always a late sign. When you look at the shock algorithm of pediatrics, hypotension is the last. Okay. BP is the last when it comes to pediatrics. So don't say, I'm waiting for the blood pressure to drop before I act. Never wait for hypotension before recognizing shock in what? In what? In children. So these are the things you should know. Okay. So on that note, we are moving to what? Compensated versus hypotensive shock in pediatrics. So let's look at this child. Imagine this child has a heart rate of 175. You people said the heart rate is either the highest is either 70, 60 or 50, 150. Okay, 160 or 150. This child is having 175. Is it tachycardia? You check the extremities, it's very cold. Also, peripherals, the pulses are weak. You did capillary refill, you had 4 seconds, but the blood pressure is still normal. The child is 12 years old. This child can still have shock. Okay. Why? Because the blood pressure is compensating. The shock has started already, but the blood pressure is compensating so that the circulatory system will not collapse. That is it. So the adrenalines and all the kidneys are giving us the adrenalines and all those ones to squeeze the blood vessel so that the blood pressure will be up. When they also give up, that is just the circulatory system is collapsed. Okay, so this is what we call compensated shock. Compensated shock. Okay, now the BP in this child, now the BP has started falling, dropping. Okay, when it started dropping, it becomes what? Hypotensive shock. Know the difference. Hypertension was derived from what? Blood pressure. So when blood pressure goes up, we say hyper. Okay. When blood pressure goes low, we say hypotension. Hypo. But you saw a shock sign here, and the blood pressure was normal. Yes, the shock is happening in the patient, but the blood pressure is normal. So anytime the blood pressure is at the normal or above, we call it what? A compensation shock. Always remember this diagram I'm drawing here. Remember, always pediatrics, keep your eyes on the blood pressure. Okay, if the blood pressure above this normal line or at the normal line or around it here, it is what? Compensatory shock. If it goes below the normal line and coming down, that should tell you that the circulatory system is collapsing. Okay, so we call it what? Hypo, because this shock has entered into the hypotensive zone or below the normal blood pressure zone. So hypotensive zone. So hypotensive shock will be the new diagnosis. Some doctors will diagnose what? compensatory shock with low blood pressure in pediatrics. You just be looking at it, then you laugh. Okay, so yes, so these are the things you should know. Okay, okay. Somebody is asking, can you talk more on the capillary refill? Yes, so capillary refill. I mean, you know your capillaries now. Okay, keep the question. I'll talk about it when I'm done. Okay, so keep the question. Keep it. Or you can copy it when I'm done. Then you paste it. I will see it and talk about it for you. Okay. Right. Now we've done the A, B, C's. Let's go to the D. That's still in D is always disability, whether it's adult or what? Pediatrics. Whether it's adult or pediatrics, is disability. Okay. Yes. So what is disability? This is physiological disability. When you see disability in ABCD algorithm, it is physiological, not disability as the eyes are closed, or the hands is cut off, or the legs, the person cannot walk. That is not the disability we are talking about. This is called neurological or physiological disabilities. Okay, so what is happening to the brain? What is happening to the brain? What to make the brain crash? What will not make the brain stay on top? Okay, so we do a rapid neurological assessment. Okay, neurological assessment, we have the neuro assessment, NA. We have the rapid, and we have what? The extensive, or yes, extensive. Okay, take note. If you work at the neuro ward, we have what? The rapid assessment and the extensive or the in-depth. The extensive or the in-depth. As a nurse who wants to be quick with your assessment, don't go for this. We do this for patients. Maybe they have been stabilized, they are on the ward, they are on the neuro ward. We took a patient to the neuro theater for surgery, is back. Okay, we are doing it for them. Patient is in ICU. We do extensive neurological assessments. You can do this and add up. And even with extensive assessment, it's the rapid is also inside. But some aspect of the extensive, we have taken it and used it to form the rapid. So when you are doing rapid assessment, we have the AVPU. That is one. Then we have the GCS. That is two. That's it. Note this, and that is it. All these ones goes with your disability. And disability is about the brain crashing. Okay. So let's look at it. Let's take the AVPU, then we do the GCS. Okay. So a quick assessment, look and listen, look and listen, look and listen. So what are we looking? Level of consciousness. Is this patient conscious, lethargic, or what? Or they are confused, agitated. That is where you are seeing the patient. Look at the pupils. What is the size of the pupils? Are they reactive to light, or they are stiff or static? Is there any seizure activity, electrolyte imbalance in children, vomiting and diarrhea? Okay, seizure activity, severe. Parents don't have money. They've kept the patient at home for so many days. Patient came with severe dehydration, electrolyte imbalance, cold extremities, seizure activities ongoing, status in nature. Okay, so you saw it. What is their glucose level? The brain eats what? Oxygen and what? Glucose. That's it. Don't go and give the brain fat. Don't go and give the brain lipid. It doesn't use it. Don't go and give the brain protein. They eat glucose or oxygen. So if you want to do brain assessment and you don't check glucose, the blood glucose of the patient, you are doing nasty job. Okay. The brain does not eat carbon dioxide. They breathe in oxygen, okay, to help it to survive. So that is what you should know. Okay, now let's continue. So this is a rapid thing you should know. So let's take the AFCON. Is the patient alert? Okay, yes, they are alert. Then you check. Are they responsive to voice? Yes, they are responsive to voice. Are they responsive to pain? Yes, they are responsive. Are they unresponsive? Okay. So this one is a quick, you will not even spend 10 seconds. You are done. You have done neurological assessment. So it deteriorates, or deterioration can be secondary to hypoxia or shock, not necessarily a brain disorder, like I told you. Okay. So always think physiologically. Now let's look at the other quick format, GCS, which is very nice. Me, I like using the AFPU and the ER. I'm gone. Okay, GCS is quick, but sometimes it delays. But I have an acronym for you guys. So I have a mnemonic for you guys. So you write it down, get your pen and papers. Okay. Right. So GCS is another quick way to do a neuro assessment on any patient, whether a child or adult. But we are doing pediatrics, so let's concentrate on pediatrics. Okay. So you should, if you want to use the GCS, score it. You have to write the score. Okay. So when I come to your house and you are sleeping and I knock, ka 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 ka. Okay. Ka 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 ka. You are still sleeping. Ka 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 ka. You are still sleeping. Now you heard me. You heard me. Oh. So you first of all you do what? You open your eyes. You are sleeping. You heard. Yes. But you before you will not close your eyes and come to the door and open the door. You open your eyes first. So when you open your eyes, the next thing you will say is, who is at the door or who is that? Okay. Because if your father is coming to your room, he will not knock. If your mother is coming, so it's a stranger who will knock. Though our parents can sometimes act as strangers and they knock when they are coming to our room because they want to respect us and our privacies. Okay. So you ask the person who is at the door. The action is the verbal action. That thing you did is a brain function activity, but you didn't know. Everybody does it. Tell me you've never done this before. You exercise your brain, but you didn't know that you were exercising the brain. Okay. Then we have what? Now you say, oh, it's Ayarega, oh, your friend, oh, Ayarega, I've been waiting for you all this while. Wait for me, I'm coming. You now get up from the bed, go and dress up or whatever, go and open the door. That walking is a motor response. Okay. Now let's come back to our eye. You went to meet somebody who is sleeping. You met somebody who is sleeping. Okay. You knock. You call. You first call the person. The person did not hear. You shake them. You pinch them. You do whatever. You put pressure on their body, especially their chest pressure. You pin their skin for pain. Whatever. They did not hear, or they did not open their eyes. That is no response. So one. When they open their eye to pain or pressure, P, pressure. Somebody will come to the ER, especially the young girls. They want to fake that they have collapsed. Do this. Pressure, chest pressure. No matter who you are, you open your eyes. Unless if they don't open their eyes, then it means that, oh, okay, this is a serious problem. Okay. Don't go for pain first. Always go for pressure first. Okay. So that is two. Now you call them, okay, you call them to speech. They open their eyes. That is three. Okay. Some of them too, your presence alone, you have not even spoken, you've not done anything. Okay. They open their eyes. The fact that you enter their room, your presence alone, they open their eye. That is spontaneous eye opening without any stimulation. So take note of that. When you are doing your assessment, a lot of people, they will go to patient's room and they will go and call them Ayariga. Ayariga will open the eyes. They will say score 4. It's a lie. Ayariga opened the eye because you talked. So that will be 3. Okay. If I enter your room, you are sleeping, or you are brought by the ambulance. I came closer to you, you open your eye. That is 4. I did not do anything, but you have opened your eyes. That is 4. Without any stimulation. Okay. So let's look at the first letters here. The first letters here. Oh, sorry. So the first letter here, the spontaneous. That is the I. Okay. The eye opens spontaneously. Okay. Eye opens spontaneously. That is spontaneous eye opening. Let's go here. The second one is to speech. The third one is to pain or pressure. But you pick one of the P's. And the last one is N, no response. Okay, no response. We don't have 0 GCS. So always you start with number 1. So you always start from low to high, low to high, low to high, low to high, low to... When you are climbing the tree, you climb from the lowest part to the highest part. So when you are scoring eye movement, you score from the lowest part to the highest part. So if you don't have 0, this will be 1, 2, 3, 4. Now let me bring the acronym here. Let me take this E here, and let me take this S here, and let me take one of these P here, and let me take one of the N. Which acronym do I have? ESPN. Those of you who follow soccer or who follow sports, ESPN, you are done. Okay, ESPN, you are done. Okay, ESPN, you are done. Write it down. ESPN. 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 Okay, let's continue. ESPN. Now let's go to this one, verbal. So with verbal, the same thing. Okay, no response, incomprehensible sound. This is where a lot of people get it wrong. When we were doing a stroke, we learned about sound and words. Okay, if somebody is having stroke, they have issues with sound. Okay, sound, hoarseness of voice is a sound. The words, slurred speech, slurred speech, okay, is words, inappropriate words. Okay, when I am coming from your lungs to your mouth, I'll first meet your voice box, your larynx, before I meet your tongue in your mouth. Take note, because these two, that is where a lot of people get confused. They mix it up. Always they use words before sound. No. Sound before words. So when you're coming from the throat to the mouth, you meet your voice box before your tongue in your mouth. Okay. So I entered your room. I called you. I pinned you. I did everything. I called, like you did not talk. Okay. That is no response. So that is going to be N. Let me bring my pencil. This is going to be, so let's take the no, the N here. Incomprehensible sounds. So that is what the IS. Inappropriate words. That is going to be the IW. Confusion comes in. That is number 4. If you don't talk, how will I know you are confused? Ayarega, what is your name? Did you bring my cuckoo? Did you get here? I want to read. I want to do this. Okay, you are confused. People will look at you and say you are confused. You don't know what you are saying. I asked you a question, you are giving me different answers. Yes, you are talking, your words are okay, articulation is perfect, but you are not answering my question. That is a confused presentation. Okay, yes, so you are confused. So if I don't produce sound, there can be worse. And if I don't speak, nobody will know I'm confused. Okay, then the last one is orientation, the O. There is a certain ward in the hospital, we call it the NICU or Nicholas, NICU, NU. I generated this acronym from this word when I was in nursing training, and it has been with me till today. So what did I do? Because I was struggling to learn the verbal response. I was really struggling with it. Okay, so I chose this N here, and this IS, I chose the I, and this one too, I chose the I again, and I chose my C, and I chose my O. So you get what we call the NIICO, the NICO, coming from the hospital ward, NICU. Now I was confused with this two I here. So how did I learn it? What was the trick I used? I use the trick of if I am traveling from my throat to my mouth, I will meet words before I see my tongue. And if my tongue doesn't talk, nobody will know whether I'm confused or not. So I see the first I should be what? Incomprehensible sounds. And the second I is what? Inappropriate words. Am I making sense for you guys? This is what has helped me till today, and I'm transferring it to you. That one day, if I die, you also transfer it to someone. That is how come generations will still benefit from the past. Okay. And yes, patient is oriented. He talks, he does everything. He knows where he is, no issues. So that is the NICU. So the I opening the ESPN, and here is the NICU. Okay, let's go to the motor response. The motor response. So the motor 2, there is an N here. There is an A here. A and what? The E. There is another A and F here. There is a W here for withdrawals. I'll pinch you or I'll touch you, but you withdraw from me. Okay. But and another one is localizing the L. And the third one is okay. So what did I do? I pick my N here. And this A and E, I pick the E. Okay. And over here too, I pick the F. And this one, I pick what? The W. And this, the L. And here, the W, the O. So it is called the Nef Wulo. The Nef Wulo. The Nef Wulo. The Nef Wulo. So no response, extension, flexion. Because these two also confuse a lot of people. This is abdominal muscle assessment. So are they, when I touch you, are you flexing, extending your hand? When I touch you, are you, this is flexion and this is extension. So when I touch you, did you extend? Or when I touch you, did you flex? Okay. When I pinch you, did you withdraw? Or when I pinch you, did you bring your other hand to localize it? Okay, that is why. So it is what we call the nerve flow. Please write it down. The nerve flow. Okay, so the I is the ESPN. The verbal is our NICU word. So the NICU. And that's it. So this is a quick assessment, but ask yourself, will you choose this in a patient who is dying, or you choose the after and go your way? So me, if you come to me, I choose the after and I do my quick assessment. When you stabilize, or when you come to me on the ward that you are a stable patient, I do my GCS. Or when you are okay, I do my GCS and I go. And I've told you we don't have zero GCS. So it starts with one. So all the words add one, counting numbers 1, 2, 3, 4, 5, 6. Here, 1, 2, 3, 4, 5. Here, 1, 2, 3, 4. Then you add them. Then you add whatever you get for. If you get here 2, okay. Here you get 3. Here you got 5. 2 plus 3, 8 plus 5, 10. 2 plus 3, 5 plus 5, 10. So GCS is 10. Then you come to the lower bundle. I mean Zoom. If it was Zoom, I just clear this and everything will go. Yeah, you have to. Okay. So we are going down. Sorry, let me clean this one quick. But write it down. Write it down. Okay. Write it down. Write it down. Right. So I'm squeezing the page a little. Now you have done your GCS. Go and score it. This is the most important part that people get it wrong always. Wrong always. Wrong always. Wrong always. GCS will end in 15. Okay. It will end at 15. It will end at 15. It will end at 15. Take note. So here, if it ends at 15, then if I get and it start at 3, it end at 15 and it start at 3. Okay. So if 3 to 8, 3 to 8, let me show you one trick here. This is 3. Add 5 to 3 because the end is 15, multiples of 5. Add 5 to 3, you get 8. Okay. Now this 15, take 2 from it. I don't know how best you can catch this trick. If you want to look at the upper side, if you want to start at 15, take 2 from it. Okay, you will get 13. So you've got your bundle for mild injury. Okay. Now, if you want to start at the lower side, add 5 to 8. You get 8. So 3 to 8. You have what? If a patient can reach GCS from 3 to 8, it's a severe brain injury. Okay, or nervous system injury. Okay, so sometimes we intubate them. Then, if they are within 13 to 15, it's mild. In between this one, I mean, this one, because you have your 13 to 15. So if anything below 13 is mild, anything above 8 is mild. So 9 to here is mild. That's it. Okay, now to it's mild. So you go your way. Catch the trick. Catch it. I've taken my time for GCS. The rest we are going, we are speeding. Okay, because I'm not dropping this. I'm not teaching tomorrow, so I need to finish everything today. Okay, let's continue. So you know how to do your GCS. you know how to score them. Okay. So your intubation, your all these ones, you know how to. Now let's go to exposure. Exposure. We do exposure for children and adults. Expose sometimes you trauma exposure, you cut their clothes. Every nurse should have a scissors, cut their clothes, or ask their mother, can I remove your clothes? Inspect their body mapping from head to toe. Did you see any rash? Was there any trauma? Was there any cut? Was there any burns? Is there any bleeding under the skin or whatever? Purpura and petechia. Is there any swelling in any part of their body? We call it trauma naked. Okay, that's the last thing you do for your ABCDE algorithm. So your E, bring out your scissors for adult who is unconscious, no family member around, cut it, cut their clothes. For a child brought by their mother, you can't go and cut somebody's clothes when the mother is sitting there. So ask them, please, can I remove the clothes? Or can you remove your baby's clothes? Okay. Yes. Or can I take the baby's diaper? You check the groins, body mapping, skin mapping. You check their temperature, the heat, the hot and coldness of the skin. You are done. So this is all about what the powers. Now let's what bring scenarios, okay, and know how to. We are going to connect scenarios. After that, we do a little quiz. I ask you, then you show me your answer. Quick. Okay. Now, respiratory system. Somebody will come with respiratory emergencies. Let's look at the upper airways. What are the commonest respiratory emergencies we are going to look at? We are looking at all the upper airway obstructions. So, upper airway, somebody will come with what? Stridor. Conditions that present with stridor. You have croup, foreign body, anaphylaxis, and upper airway swelling. That's it. Okay, somebody has swollen, foreign body, upper airway. Some of the parents will be putting things down, they will push it down to the lungs. Okay, yes. Foreign body, you have to be careful with airway management. Okay, yes. So these are the conditions you are going to see. Okay, the lower airway, you think about the wheezing. So what conditions do we get wheezing in the lower airways? Asthma is there. Okay, bronchiolitis is there. Please, asthma is not a lung problem; it's an airway problem. Today, you know the difference now. Let's look at lung tissue. Now let's leave the airway. Let's go to the lungs. In the lung tissues, what are some of the sounds that you hear? You hear crackles plus hypoxemia because oxygen and carbon dioxide they can get stuck. Okay, yes. So if you don't hear crackles, you will see patient presenting with hypoxemia, saturation is dropping, and all those stuffs. Okay, so pneumonia conditions that can come with lung issues, pneumonia, pulmonary edema, aspiratory related lung injury. Somebody has aspirated gastric content full of hydrochloric acid straight into the lungs. It's going to burn the lungs. So they get what? Aspiration pneumonia. Okay, somebody took poison, children. Some of the poison will, or all these Dettol and all these organophosphate issues. These bathroom chemicals we use to scrub the bathtubs. Children will drink it. If you are not careful, they can even aspirate. When they aspirate, it is going to cause lung injuries, aspiration related issues. Okay, now let's look at what we have another diagnosis. People don't know, it's very common. We call it disordered control of breathing. Okay, so patient will come with abnormal respiratory rate, okay, or effort without a primary airway problem. Example, yes, I check a baby has come or adult has come. Okay, but let me forget about the adult. Let's do babies. A baby has come. The abnormal, the respiratory you check it was abnormal, super high or low. Okay, But you can't see any obstruction. You can't see any lung injury. You can't see any problem with the airway. But why is the respiratory rates abnormal? Or why are they using their accessories of breathing, accessory muscles? Where is the problem coming from? Okay, we have what? Seizure, especially in the post-tical state. Drug abuse. Somebody will be abusing drugs, drug overdose. Children, they went to take their mother's oral morphine, drank it. Okay, it has suppressed the respiratory rates. Head injuries, children, central nervous system infection, meningitis. Okay, all this one, parenchyma issues, the increase in intracranial pressure. So all these things affect your respiratory rate. So when a patient presents like this, we diagnose them as what? You are having a disordered control of breathing. Okay, that's it. Okay, so a person will come with croup. I want to emphasize on croup because there's a trick here, especially those who are going to write NCLEX. Open your eyes, listen to me very well. Croup, okay. If you meet it, shine your eyes. I'm showing you some trick today. A child will come with a mother will bring the child with croup. Yes, this one is very common. Everybody knows. Let's look at croup in stridor. Croup is divided into two. Anytime you detect croup, always ask yourself, is this stable or unstable? Treat croup as like the way you treat angina or MI. You always ask yourself, is this stable or unstable? Okay. Stable or unstable? Okay. Yes, a croup patient can present with all these things, whether stable or unstable, but the stridor is the difference. Okay, the stridor. So we know everybody knows that stridor is an upper airway obstruction problem. Okay, so this child is having croup, mostly a viral or whatever infections. Okay, they are coughing, you are hearing they are barking, cough, and all those ones. Okay, but you ask yourself, was the child alert when they were having stridor? In what state of alertness? Were they crying? It is only when they cry that you hear stridor sounds. When they stop crying, you don't hear anything. Okay. When they cry or when they want to cry, that is where. So the question will pose. Shine your eyes to those who are going to write NCLEX. The child was having stridor when crying. I should tell you, this is a stable group. Okay, yes. Unstable group, they have stridor even when they are sleeping or when they are calm. When they are sleeping in their calm nature, you and I, you are sitting down calmly watching me from your homes. No, nobody is stressing your respiratory system, but you'll be having group backing cough and all those things. Okay, that's you have an unstable group. But when the baby is crying, baby is alert, when they engage in activities, then you start saying, oh, no, okay. But when they stop the activities, when they stop crying, then everything settles. That is what instability. That is a stable group. Okay. Yes. So that is the difference. So the question will come with barking cough, stridor, and all those ones. Okay. Stridor or no stridor. Sometimes they can bring this English. Stridor when at rest, or no stridor at rest. Stridor when crying, or no stridor at rest. Expect either of these two English in your NCLEX when you meet group. Shine your eyes. Okay, it's English. They change the grammar to confuse you. Okay, right. So So the diagnosis, the categories, the severity. Okay. So stable group, barking cough, hoarseness of voice, stridor, mainly when agitated. You see, they have changed the English here. It is no more crying. When the child is agitated, he cannot stay at one place. You'll be having stridor. Okay, this is a stable. But when you keep them calm, the stridor vanishes. This is a stable group. Child is alert and oriented. No severe hypoxia. They will add it. Then you are struggling. They can take this English out and still mafia you. Okay. Yes. So don't you know your steroids, your dexamethasone, you keep the baby calm. Remember, the croup is an airway obstruction. Okay. So when you keep the baby calm, the obstruction will be relieved. Patient can breathe well. So keeping them calm too is part of the intervention. That is for stable croup. Avoid unnecessary agitations. So the nurse going to work on this patient, you pack all your things, make your list. If I go, I'll check vitals, I'll give medication, I'll feed, I'll do this, I'll change diaper, I'll check the length, check the weight, write everything on paper, gather all your equipment, go and do it. When you leave the room, you leave. Not you're going to check vital 3 minutes time, you're going to check pulse, you're going to you are causing agitation in the child. Okay. It's unstable, stridor at rest. Okay. Only one thing differentiates between. So immediately you should know that what that airway obstruction is getting severe. So I must act. Most significantly, upper airway obstruction. So what do you have to do? Your steroid, you nebulize plus what your corticosteroids. Know the treatment too. With the stable group, we only give what the steroids. Okay, but with the unstabilized group, we give the epinephrine nebulized epi because it's getting serious. Okay, plus your observations and airway readiness, intubation and all those ones, trachycrico and all those stuffs. Okay, right. So stridor when they are crying is not the same as stridor when they are at rest. So stridor, when you see stridor at rest, it's a red flag. They want to trick you, shine your eyes. You. Let's go to epiglottitis. Epiglottis has inflamed. It can be infection or whatever, toxic issues. Okay. Definitely epiglottitis infection will come with fever, drooling. Okay. Dysphagia. Dysphagia is not a classical sign. Difficult swallowing is what? Tonsils. Tonsils. Tonsils, patients don't salivate a lot, but epiglottitis, they salivate a lot. Epiglottitis, patients have tripod positioning. Okay, yes, and they also have stridor. So note the difference. So sometimes they will bring it NGN and tell you to differentiate. Okay, somebody said I should go over. Okay, so uh, with the stable and unstable, with the stable group, always look at what the stridor. Okay, the stridor. Take it as this: you are having difficulty breathing. Okay, when you sleep, everything becomes fine. Okay, but another person too is having difficulty in breathing. Even when they sleep, the shortness of breath is still there. Okay. I use the word sleep because sleep means calmness. When patient is calm, everything is okay. Okay. So if you have a child like this, and this child, you know the problem of the child, that I want my baby to sleep. And another person comes, let's say children in the house, they come and make noise and the child wakes up. Will you be happy? No. Okay. Because the child is stable when they are calm or they are sleeping. But when they wake up, when they are agitated, when they are anxious, when they are aggressive, the stridor comes. That means that yes, I have a child who is having upper airway problems, but I know how to solve it. So this is a stable upper airway problem. Okay. When will I think of, let me give this condition and a serious attention? A day is coming, even when the child sleeps, they're still having what, shortness of breath, stridor, all these ones. Even when they are calm, they still have shortness of breath. That should tell you that the condition is getting worse. So I have to what? Nebulize with what? Epinephrine, adrenaline, okay? And I have to give my steroids and prepare for intubation or upper airway maintenance. Please, you understand? Let me know in the chat box if you are okay with it. Then we continue. Okay. Now we are on epiglottitis. So I was saying that epiglottitis, especially those who are going to write exams, they will bring the drooling, they will bring the drooling, they will bring the dysphagia. When they add it, it is not a cardinal sign. It's just there. Okay. The drooling is a problem. The drooling is a problem. Okay. And the tripod position is a problem. Fever because there is infection, itis. Okay. And stridor. But the drooling is the key, is the key, is the key, is the key, is the key. Sometimes they can give you two conditions and give you these signs and symptoms. When you see dysphagia, dysphagia is a key issue in what? Tonsillitis. Okay, tonsillitis. Know the difference. And epiglottitis. So you should know those things. Never put anything in the mouth of a patient with what? Epiglottitis. Because you can either cause it to burst or cause it to swallow a lot and cause more airway obstructions. So do not unnecessarily agitate the child or attempt a casual throat examination in a child with suspected critical airway obstruction, epiglottitis. Okay. So controlled airway management with appropriate expert support. Now let's look at what foreign body obstructions. Foreign body. So a toddler is eating and suddenly stops speaking. Sound is not coming. Okay, the sound is coming from the lungs. As the CO2 is coming out, okay, it's coming from the airway. Something has blocked that airway. No air is coming out. So which air is going to pass through the voice box to produce a sound? So voice will go suddenly. How about coughing? We cough from our lungs. But patient is coughing, yes, but cannot cough effectively out. And suddenly they become cyanotic. Oxygen is not going. Okay, I should tell you that no, this child is having foreign body. So the American Heart Association will say that for a child, when a child is having a foreign body, I mean, obstruction or whatever, okay, if the child is conscious, For a conscious child, let me change this color. With obstruction, severe obstruction, whatever case, you, the rescuer, this is how you should go about it. Rescuers should use repeated cycles of back blows, followed by what? Abdominal thrusts. You are looking at a child, okay? Until the obstruction is expelled or the child becomes unresponsive. For infants, use back blows and chest thrust rather than abdominal thrust. You destroy the diaphragm. Okay. So blind finger sweep should not be performed. When you do that, you push the obstruction further down. If you have a long hands, okay. So these are the things you should take note. Okay. Right. Let's look at the lower aspect of the airway. So the lower aspects of the airway, we are looking at, sorry, I'm coming. The lower aspect of the airway, we are looking at what? Asthma. Lower airway before we go to the lungs. So lower airway, asthma, expiratory wheeze, prolonged expiration. Okay, the airway at the lower aspect is what? Swollen, fluid accumulation, and all those ones. Okay, like some serious reaction going on down below. There are retractions and decreased air entry. CO2 is building. So oxygen as needed. So a patient like this, your ABCD should have done. You give your oxygen, you know where the problem is coming from. Asthma. If you are lucky and the patient tells you I'm an asthmatic patient, but if you are not lucky and the patient hide it, that is where the thing will be difficult because you have to be smart to know. Okay. Oxygen as indicated. Inhaled acting bronchodilator, such as albuterol. Fast acting. Okay. Hypertropium for significant exacerbations. Then what? Systemic corticosteroids. Okay. Then additional escalation for severe retractions is very important. But again, do not treat the wheeze alone in asthmatic. Treat the child. But the problem is coming from somewhere. Okay. The dangerous asthmatic patient. This child is 12 years old. Respiratory rate is 44. Heart rate is 150. Loud wheezing. 12 years old. 30 minutes later, let's look at the respiratory rate. It has dropped down from 44 in the space of 30 minutes to 18. Heart rate is 45. Very sleepy, minimal wheezing, and barely moving air. So the boy, the student, he says that the respiratory rate and wheezing has improved. This is a wrong interpretation. The child may be what? Exhausting. So quiet lungs plus decreasing consciousness is a potential impending respiratory failure. So you shine your eyes to that. Okay. You shine your eyes to that. So somebody is asking, what is the classical sign to what? To this condition? Which condition are you talking about? Classical sign to this condition. If you can specify which condition, we've done asthma, we've done all those stuffs. Okay. So let me know the condition. Now, bronchiolitis, we are still in the lower aspect. Okay. Bronchiolitis. So, bronchiolitis, what is causing an inflammation in the bronchioles, in the bronchial tree? Okay. So, is that a viral We have the tachypneas, the wheezing, the crackle, the retraction, the nasal congestions, and feeding difficulty for children. So here, management is predominantly supportive care, and particularly airway or nasal secretions management. You hydrate the child, oxygen, and or respiratory support according to severity. Okay, according to severity. Now let's go to the lungs. We've done with the airway. Lungs. A child will come with pneumonia. So pneumonia will present as what? Fever, tachypnea, crackles, hypoxemia, increased work of breathing. So the child may progress from what? Respiratory distress to failure. Then the heart will stop if you don't work on this child with pneumonia. For a child to have pneumonia, it means the problem has crossed what? You first you first see the airways before you go to the lungs. Okay. Now the problem is sitting in the lungs. Yes, it's damaging everything. So you have to, and the lungs, when it damages, it's not like the liver. When the lung damages, it cannot repair itself. That's why a lot of people died from COVID-19. Okay. I've done disordered control of breathing for you. Respiratory rate, a teenager, you saw a teenager or you found a teenager found on the bedside with empty bottles of opioid. Okay. You check the respiratory rate, it was 5. Shallow breathing, pinpoint pupils. This is what? A disordered control of breathing problem. So we need to reverse the opioid and give the patient oxygen. Immediate priorities: airway, effective ventilation, oxygen. Okay. Do not wait for naloxone to work before ventilating the patient for an apneic or hypoventilating child. Okay. Yes. So that is how it is. Now let's look at shock. Let's go to the cardiovascular system. Shock. Okay. Everybody knows that shock is what? Inadequate delivery of oxygen, nutrients in the form of blood and all those stuffs to what? The cells. So we are having metabolic demands. Supply are not meeting the demands. So acidosis and all these stuffs will come in and cause. Okay. You have the types. You have hypovolemic shock. So there is loss of circulating volume. We all know this. I'm going to go through quick. Okay. Example, a child will come with vomiting, diarrhea, burns, hemorrhage. Okay. Hypovolemia. Okay. Distributive. We see the abnormal vascular tone or the distribution. Okay. Like what? Sepsis, anaphylaxis, all these ones are hot. When we did the cardiovascular system, we did shock. That's what I'm going through. Okay. So the vascular tonicity, distribution, what? Shock. Cardio, about the heart. So pump failure. We see children with what? Myocarditis, cardiomyopathies, congenital heart disease, arrhythmias. Children are growing. They get what? Yes, you will get a slide after the class. Okay. I always post it to the page. Obstructive. Okay. It's something obstructing the lungs or obstructing the heart. That's it. Obstructing the lungs or obstructing the heart. So, what are some of the things that can obstruct the lungs? Tension pneumothorax is crushing the lungs. The lungs cannot expand, okay, to accommodate a lot of oxygen and push it into the circulatory system. What are some of the things that can surround around the heart and crush it? Cardiac tamponade. Okay, that is it. Massive pulmonary embolic obstruction is an appropriate circumstance. Okay. So the current PAR guidelines addresses shock phenotypes, the various types, and emphasizes reassessment because Fluid and vasoactive strategies depend on the underlying physiology. In adults, when somebody's blood pressure is crashing, the next thing we're looking at is fluid. But for children, what this American Heart Association is saying is that don't rush to give fluid when you start suspecting shock in children, but rather what? Focus on the underlying physiology. Because a child who is having what? Cardiomyopathy, if you go and give fluid, you cause more problems. Or cardiac tamponade, a lot of fluid or blood around the heart. The heart cannot expand to take a lot of blood into the ventricles and move to the system. Okay, yes, so you do cardiocentesis for this child. Okay, how do you recognize shock? So you see, if you look at the American Heart Association algorithm for pediatric shock, they say what? The heart, the pulses, the skin. Okay, at this stage, the child is having a shock. But the nurse who doesn't know left from right is waiting for the BP to drop. The brain, then the kidneys with low urine output. And finally, you get hypotensive shock. So all these ones are what? Compensatory shocks. Okay. So what are the signs and symptoms you are going to look for in this patient? The tachycardias, the weak pulses, okay, the delayed cap refills, the mottled or cool skin, altered mental status, reduced urine output, and hypotension. Okay, hypotension. Do not wait for low blood pressure. So hypovolemic shock, a child with what? 5 years old with diarrhea. Heart rate is 175, respiration rate 38, cap refill is 5, dry mucous membrane, weak pulses, and cold extremity. Think about hypo. So you do your ABC stabilization, D, and exposure. That is it. IV fluid or intraosseous access, isotonic crystalloid resuscitation as appropriate. Because you have seen that this is a clear case of what? Hypovolemic shock. Okay. And frequent reassessment. So you assess all this and you know it already. So I don't have to go through again. A child with septic shock, you see your fever, heart rate is shooting up, sometimes over 200, arrhythmias, altered mental status, cap ratio 5 and above or higher, weak pulses and hypothermic. Okay, yes, shock. So you do the shock or the septic workout, your ABC stabilization, your oxygen ventilation when needed, IV fluids for IVs, blood works, okay, then appropriate fluid resuscitation, then early antimicrobial therapy. If needed, vasoactive support, ephedrine, noradrenaline, okay, or norepinephrine, okay. Yes. Fluid administration must not become automatic when you are treating shock for kids. Reassess for evidence of fluid overload and myocardial dysfunction before you go. Okay. A cardiogenic shock. You see, here's the trick. Okay. The child is having tachycardia, weak pulses, cold extremities, hepatomegaly from the scan, the CT scan or the abdominal scan, crackles in the lungs. Okay, respiratory distress. That is why a lot of people get it wrong. Do you automatically push repeated large fluid volumes? No, because you saw this, because you saw tachycardia, you are going to give plenty fluid. You will stop the heart. You see where the problem is coming from? It's coming from the lungs. Then you see some hepatomegaly here, cool extremities. Yes. Okay. I should tell you that what the blood is not going. Blood is warm, it should be able to go to every corner of the body, of the skin, to keep that place warm. So you see the cool extremities and the tachycardia, and the pulses are weak. Shine your eyes sometimes. Okay. Shine your eyes. Especially with these crackles, she tell you that no, a lot of fluid down there. Okay. So the pump is failing. It's failing, ing. So this is why PALS requires you to do what? To recognize the shock type, not simply memorizing it. Physiology counts. Okay. Bradycardia, we are still in the cardiovascular system. So we've done our shock. Okay. Let's do bradycardia, pediatric bradycardia. So a child will come with what? Bradycardia. I've told you that before the heart will crash, it's either the circulatory system or what? The respiratory system. So a child has come with bradycardia. Think about these things, not every time, but frequently enough that ventilation is a central early intervention. Okay, so let's look at some scenarios. A child 3 years old, heart rate is 50, 52. You did your heart rates. Respiration rate is 6. Patient is cyanotic, lethargic, and weak pulses. What comes first to your mind? Somebody will say, give atropine because the patient is unstable. This is a child. You are dealing with a child. Start from the airways, breathing. Okay. Yes. Okay. Don't rush. Your airway, the oxygenation, ventilation. So American Heart Association will come that what? The pediatric bradycardia algorithm directs clinicians to maintain the airway, provide oxygen and positive pressure ventilation when necessary, and monitor the patient. If CPR or cardiopulmonary compromise persists and the heart rate drops below 60, you begin your CPR. If the so after doing everything and still the bradycardia is still persisting, with the heart rate below 60 and cardiopulmonary compromise, despite everything you have done, you start your CPR, your IV lines, your epinephrine, okay, never go above 1. So you are giving 0.01 child milligram, 0.01, you are giving, never go above 1 milligram. The maximum single dose listed in the current algorithm is, okay, or with children, 0.01. Okay. Atropine. Atropine is particularly considered when bradycardia results from increased vagal tone, children, or primary AV block. So atropine 0.02, I mean, you give it. So 0.023, this is the dosage. Don't give 0.1, 0.2, 0.3. It's too much. Children, small one, drop it in their IV. Okay, it goes. Okay. So bradycardia, memory rule, oxygen ventilation, CPR, epinephrine, do your cardiac arrest algorithm. Okay. Let's look at the other side of tachycardia, pediatric tachy. Okay. You ask yourself, when you see a child's heart rate going up, you ask yourself, this heart rate I'm seeing up, is it a sinus tachycardia or an SVT? The T is a sinus tachycardia or an SVT. This distinction appears repeatedly in power scenario. So let's look at the case of what? Tachycardia. What will make a child's heart rate go up? Fever or the stresses. The fever, the anxiety, the hypovolemia, the H and the T's, the sepsis. Okay. You treat the cause, not merely the heart. Children don't mostly have heart problems. So treat the cause. A child has come with a very fast heart rate, over 200, 190. Okay. It just started. The mother will tell you that it just started. You check the heart rate, super high. Abrupt onset. When you see this English, it is mostly related to what SVT. Tachycardia, sinus tachycardia is gentle. It will keep climbing until it triggers. Okay, yes. So little bit to bit variability, narrow QRS complex. P waves may be difficult to identify because the QRS complex has swallowed. I've told you that when the P wave and the QRS they meet at the junction, the QRS always swallow the P wave. Okay, so you do your Vega maneuvers for SVT. Okay, you look out for your HNTs. Then another thing, when you are dealing with SVT, ask yourself, the patient stable or unstable? This one goes for all patients. Are they stable or unstable? Okay, are they stable or unstable? So if they are stable SVT can proceed through Vega maneuvers. Okay, so the Vega, if they are adults, you can give them some, let's say, a syringe to blow. Okay, they can do the reverse Trendelenburg. Okay, and all those ones. If they are unstable, okay, if they are unstable SVT, that is where you do your cardioversion and all those ones. Okay, yes. So that is what. So then finally, if a child arrests on you, if a child arrests on you, the child will definitely not be responsive. No breathing and no pulse. As a health worker, don't waste your time checking a pulse for more than 10 seconds. Oh, Semre, you are wasting time. It's a definite pulse, not felt in the child with no sign. Begin compression. Okay. Then you assess when the part and everything comes. Is it shockable, non-shockable? We know all this. Okay, shockable rhythm are two. VFib or what pulseless VTAC. If it is not about the ventricle, if it is not slow or high, even if it is high and I don't feel a pulse, VTAC. Every other thing non-shockable. This is two. Okay, good. Then sometimes you can see a good EKG. Okay, don't. Oh, that's why you shouldn't always rely on. I've seen an EKG, P wave, QRS. Yes, T. You have shocked the patient too, and the rhythm has changed. P wave, QRS. Okay, T. Nice pattern. But you still have to check the pulse. Check the pulses, the femorals and the all those ones. Check it. Is there pulse? If there is pulse, this is sinus. If there is no pulse, this is pulseless electrical activity. PEA. So don't let them trick you. The question will bring something simple like this, okay, and tell you that the patient does not have a pulse. It's pulseless electrical activity. A lot of people get confused, especially CPR team. They get confused because when they shock the patient or when they assess the rhythm and they see this nice wave patterns, they say, patient has recovered, let's leave and go. The patient will go and rearrest again. Okay. That is why it is very important to do your ROSC, return of spontaneous circulation. Okay, monitor the patient, take patient to ICU. Okay. Any nurse or health worker who is doing high quality CPR with children, remember the heart rate of children is 110 to 150 or 160. Okay. So ask yourself, can I press that within 60 seconds? So you should be fast. It should not be slower like the way you do it. A lot of people are more tuned to the adult CPR. So when they are doing pediatric CPR, they are very slow in their rate. You have to be fast. You have to be hard, full and minimal. Okay. So these are the things you should know. Maintain a full what chest recoil and also minimal interactions. Don't waste time more than 10 seconds on pulse checking. Okay. Now, whilst you're doing the CPR, whilst everything is going, or whilst the treatment, everything is over, we check for the H and the T's. These are the causes. Children will never hide. Definitely, one of these is causing that. Is it hypovolemia? Is it acidosis in perfusion issues? Is it hyperkalemia or hypo? Is it hypothermia, temperature? And the T's, is it tension pneumothorax, tamponade, toxins, or thrombosis, clots? Okay, yes. So, getting to an end, okay, of today's scenarios, this is what I would drill everybody into. When you get a case, let's go over, let's recap. When the case comes, look and listen, look and listen. So what do I see? What is the appearance? The ABC triangle, the ABC triangle, the ABC triangle, the ABC triangle, the ABC triangle. Never forget to the ABC triangle. You gave your child to someone, you went to take your child back. The ABC triangle, the appearance of the child, the breathing, and the circulation, the ABC. Once you do this, then you triage or you make your decision. The next point is what? To assess. I found a problem in A. Let me do my ABCD. I found a problem in B. Let me do my ABCD. I found a problem in C. Let me do my ABCD. Okay? Good. So let's continue down. After you do your assessment, you classify. Is this a respiratory problem? Is it whatever? Okay. You determine the severity of is the patient stable, distress? Are they having failure? Are they having shock? If it is shock, is it compensated or hypotensive shock? Is it cardiopulmonary compromise? Is there arrest? Then you intervene. That's it. So after your intervention, ask yourself, has the problem resolved or not? Let me reassess. Even when they resolve, you still have to do continuous reassessment of the patient. If not, you escalate. Okay. Yes. A mother has brought the child with what? Burns. So burns, a baby who has had burns. Okay. Stridor will tell you what? Upper airway. Wheezing is a lower airway. When you hear crackles, we are dealing benzo. When you hear crackles, it's a lung problem. Okay. When their respiratory rate is very irregular, whether high or low, but you can't see any issue about what? Any problem, direct problem with the respiratory system. Okay. It's not asthmatic, it's not no choking, nothing. This is what we call disordered control of breathing. Okay. A child has been brought to you, heart rate is high, capillary refill is delayed, normal blood pressure is compensated, shock. Once BP start dropping, it turns into hypotensive shock. A child with heart rate 50, poor perfusion, despite you have given oxygen, done everything, still 50. Okay, you can't treat them like an adult, start your CPR. A child has come backing cough and all those stuff, group. Okay, if is it less stable, is it stable or unstable? So you know the stridor at rest or stridor when sleeping. Okay, yeah. Foreign body in the airways. Patient is having sudden choking, suddenly they can't talk. When they cough too, it is not coming out well, all those types, foreign body. Okay. Maybe you are not in the hall, the child is in the hall alone, you are in the room, you came, they are having all this presentation. It's a foreign body signs and symptom. Okay. The child is having very fast, narrow, irregular rhythm with abrupt onset. Take one on. I've highlighted this one. Abrupt onset. Think about SVT. Okay. They can have this rapid, narrow complexes, rapid heart rates, and all those ones. But if it is not abrupt onset, it is what? Sinus tachy. Know that. No pause, cardiac arrest algorithm. Cardiac arrest algorithm. Okay. Right. So, guys, this is all I can say for today. Thank you so much. Let's do this quick questions. I'll give the rest to you. Go and serve it at home. So I've got all these questions for you. I've got all these questions for you. Okay. Or you want us to? No, I can't do class tomorrow. I'll go to work. Okay. So when you get the questions, let's do these quick questions. There are a lot. So those of you who are going to write NCLEX very soon, I intentionally got these questions for you. Okay, right. So, okay, let's do this one. Here is it. So, a child is having backing cough with stridor while crying. Number one, type your answers. Let's solve it quick. There are about 12 questions. Let's solve. Number one, yes. Number one, the first finger group. Okay, good. More answers. More answers. Okay, whilst crying. Cool. Okay. This child is having stridor at rest plus severe retractions. What has changed? The question is, what has changed? Yes, number two. Number two. This number one child he's still having the stridor, but now the stridor at rest. Okay. And having severe retractions when breathing. Yes. Good. Good. You guys are good. It means you were following. Yes. Number three, the child is having expiratory wheeze plus prolonged expiration. What condition is that? Expiratory wheeze plus prolonged expiration. What has changed? Which respiratory category is that? Which condition is that? Number three. Yes, number three. Number three. Send me your answers. Yes. Expiratory wheeze plus prolonged expiration. Yes. Good. 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 Okay. Number four. This child is asthma. Okay. But you did the auscultations. You heard a silent chest. And the child is drowsy. Number four. The child is drowsy. What are you looking at? Number four. What is there improvement? Is there improvement or deterioration? Is there improvement? Number four. Is there improvement or deterioration? Is there improvement or deterioration? Yes. Okay. Number five. Let's do number five. Okay. This child is having crackles plus fever and hypoxemia. Which condition are we looking at? Which respiratory category? Fever plus crackles plus hypoxemia. Crackles, hypoxemia. Crackles and fever, hypoxemia. I love this is a clinical Q question. Okay. Clinical Q question. I love it. I love your answers. Wow. 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 That is a case of pneumonia. I'm not answering it. When you get it, answer it yourself. Okay. I've told you. Number 6. A child has come with a respiratory rate 5 after opioid exposure. Which condition, respiratory condition are you looking at? Number 6. Number 6. Number 6. Yes. Yes. Somebody will say opioid toxicity, but what category? What respiratory category are you looking at? Respiratory category are you looking at? Disordered breathing control. Okay. Disordered breathing control. Don't forget to disordered breathing. Yes, he has ingested toxins. Okay. He's having respiration rate of 5 after opioid exposure. Disordered control of breathing. Disordered control of breathing. Disordered control of breathing. Okay. Yes, write it so that you won't forget. Right? Disordered control of breathing. Okay, let's go to number 7. This patient is having tachycardia plus weak pulse and normal blood pressure. What type of shock is that? Number 7. What type of shock? What type of shock? Number 7. What type of shock? Tachycardia, weak pulses, and normal blood pressure. Let's type fast. We have 30 minutes for our time to be up for today. What type of shock? Yes. Number 7. Yes. Number 7. What type of shock? Yes. Tachycardia, weak pulses, normal blood pressure. What stage of shock? Sorry. What stage of shock? Okay. What stage of shock? Yes. So it's a compensated shock. Okay. Number 8. This child is now having tachycardia, weak pulses, and hypotension. So what stage? What stage? Yes. Number 8. This child is now having tachycardia, weak pulses, and hypotension. Yes. Which stage? Before the child was having tachycardia, weak pulses, normal BP. Now the child is having hypotension on top. Yes. Yes. Which stage? Which stage of shock is number 8? Shoot. It is not uncompensated shock. I want the stage of shock. Hypo, yes. We said it. Today we have not spoken about uncompensated or compensated shock. Yes. I told you that use the blood pressure. Use the blood pressure. So we have the normal blood pressure above normal. So this is normal, higher and lower. Yes. Yes. How do you know this is hypovolemic shock? How do you know? Come again with your number 8 answer. Remember this. This is a normal. This is above normal. This is below normal. So what type of shock is number 8? This is a hypo. So hypotension shock. Example is hypovolemic. Okay, hypotension shock. Okay, number 9. Let's go to number 9. Number 9. This child is having hypotension, wheezing, and urticaria rash. Diagnosis and first line medication. So you are giving me two answers. Diagnosis and medication, sharp. Diagnosis and the medication, sharp. Diagnosis and medication, sharp. Diagnosis and medication. Diagnosis and medication. Diagnosis and medication. You are giving me two answers, so not one. You diagnose, then first line medication. Diagnose and first line medication. Yes, you are doing well. Good, 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 good. Give me the diagnosis. So people are writing only one. If you write one, you get half. Give me the diagnosis and the first line medication. Give me the diagnosis and the first line medication. Give me the diagnosis. Okay. So this is a clear case of what? Anaphylaxis. Okay. Then your epi and your steroids. Okay. Good. Number 10. Let's go to number 10. This child is having heart rate of 48. The child is having hypoxia and ineffective breathing. What should you correct immediately? What should you correct immediately? Number 10. What should you correct immediately? Hypoxia, heart rate 48, and ineffective breathing. What should you correct immediately? Yes. Number 10. Shoot. Number 10. Shoot. Shoot. You have 8 minutes to go. Shoot. What should you correct immediately? I didn't say you should diagnose it. Yes. 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 People are diagnosing it. Your nursing intervention. What should you correct immediately? Okay. Good. So maintaining airway and giving oxygen, very important. Okay. Yes. Number 11. This child is now having a heart rate of 60 with poor perfusion despite effective oxygen and ventilation. Despite effective oxygen and ventilation, heart rate is less than 60. What next? What next? Number 11. What next? According to American Heart Association, what are you supposed to do? What next? Yes. What next? Yes, Vivian, come again with your answer. Yes. Oh, you are not answering number 11. Yes. Yes. Good. 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 Number 12. This child is having heart rate of 240 plus narrow QRS complex, but irregular and an abrupt onset. What rhythm are we looking at here? Number 12, what is the rhythm? Number 12, what rhythm? Number 12, what I want rhythm. Yes. Yes. Good. Number 12. Number 12. Number 12. Number 12. Number 12. Wow. You guys are sharks, man. Number 13. Yes. Number 12. More answers. Yes. Number 13. This child is having SVT plus hypotension plus altered consciousness. What treatment direction? What treatment are we looking at? SVT, altered level of consciousness, and hypotension. What are we doing for this child? Okay. Yes. Yes. Number 13, SVT plus hypotension plus altered consciousness. Altered level of consciousness. Altered level of consciousness. The patient stable or unstable. SVT. Anytime you see SVT, ask yourself, is the patient stable or unstable? Altered level of consciousness. So I don't want anybody to mention Valsalva's maneuver. Yes. Without maneuver, patient is not stable. Yes. Good. Good. Okay. Number 14. This child is having pulseless ventricular fibrillation. Pulseless ventricular fibrillation. Is it shockable or unshockable? Shockable or non-shockable? Number 14. This is the question. Is it shockable or non-shockable? Sorry. Is it shockable or non-shockable? Number 14. Yes. Shoot. Is it shockable or non-shockable? Is it shockable or non-shockable? Is it shockable or non-shockable? Yes. Pulseless VFib. Is it shockable or non-shockable? Yes. Send me your answer. I want to know. Send me your answer. I want to know. Yes. This one, you should not think about it. Bah! The answer should be there. Yes. Shockable or non-shockable? Shockable or non-shockable? Yes. Shockable or non-shockable? Okay, this is a case of shockable. Okay, shockable rhythm. Number 15, pulseless asystole. Pulseless asystole. Shockable or non-shockable? Answer the question. Is it shockable or non-shockable? Yeah, number 15. Shockable or non-shockable? 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 Yes. Okay, good. So this is a non-shockable. Okay, you can shock asystole. Number 16. There is an organized rhythm but no pulse. Organized rhythm but no pulse. You check your pulse, you couldn't find it. What rhythm is that? Yes, number 16. What rhythm is that? Organized rhythm. Nicely. You see your PQRST wave, ST segment, PR segment, a PR interval. Perfect. Everything. Yes. Number 16. Number 16. Number 16. Number 16. Answers. More answers. Number 16. Yes, number 16. Number 16. Yes, what rhythm is that? Number 16. What rhythm? Some people are not answering. No. They are just watching people. Okay. Number 17, no eyes, incomprehensible sound, abnormal fleshing. Let me get you the acronym. Is it calculate the GCS? Number 17, what is the GCS? Number 17, what is the GCS? No eye opening. So ESPN, the NICO, NIICO, and the last one is the NEFLO, NEFWLO. What is the so no eye opening, incomprehensible sound, and abnormal fleshing. What is the GCS? 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 I want to know. Yes, some are saying 5, 6. Wow. I know where the differences are coming from. Yes. Incomprehensible sounds. That is where the differences is coming from. Yes. Yes. No eye opening. Incomprehensible sound. Abnormal fleshing. Okay. Yes. 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 No, you not do CPR. This one you're doing GCS. Yeah, I forgot to. Okay, so let's calculate it together. No eye opening. ESPN is N 0, so 1. Okay. Incomprehensible sound. I told you that when you are coming from your throat to your mouth, you meet your voice box before your tongue. So the sound is always comes first before the words. So this is incomprehensible sound. That is number 2. Okay. Then the fleshing. This one you should not get it wrong. The fleshing is here. The F. That is 3. So 3 plus 2 is 5 plus 1 is 6. So this is 6. Those of you who wrote 6, you got it. Okay. Eh, yes. So if you know this trick, you are done. GCS questions, you swallow all of them. Okay. You swallow all of them. You swallow all of them. Okay. Number 18. So this child is having hypertension, bradycardia, irregular breathing after head injury. What are you worried about as a nurse? Severe hypertension, bradycardia, irregular breathing after head injury. Number 18. Good. Number 18. Hey, plus smart. Hypertension, bradycardia, irregular breathing. Yes. Shoot. 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 18. We are number 18. Okay. Shoot. 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 Okay, good. ICP, good. Increase intracranial pressure. Number 19 allows but one question. Okay. We have a seizure lasting for more than 5 minutes. What type of emergency is this? Number 19, a seizure lasting more than 5 minutes. What emergency are we looking at? A child is having seizure. The seizure has sustained continuously for more than 5 minutes. Jesus Christ. What emergency are you looking at? Yes, the nurse must know. Good. Okay. Okay. Number 19. Seizure lasting more than 5 minutes. Seizure lasting more than 5 minutes. Lasting more than 5 minutes. Lasting more than. Okay. Okay. Hey, somebody said asthmatic status. Seizure is lasting. Can you see any asthmatic signs and symptoms here? Eh, it's good. It's better to make mistakes now so that I don't make mistakes in the exams. Okay. Yes. Seizure lasting more than 5 minutes. Hey, the GCS question, somebody said the answer is 4. Wow. Just chat me after class. Yes. Shoot. Yeah, shoot. Good. Number 20. 20. Our last question, then we say goodbye today. Okay. This child is having deep, rapid respiration or breathing, plus hyperglycemia, plus dehydration. What metabolic emergency are you looking at? Deep, rapid respiration, dehydration, hyperglycemia. Hey, you who are using AI to answer my questions. I suspect all of you, Caleb and Co. You who are using your eyes are AI. This last question, it was very tricky. People are blowing it already. Hey, Charlie, I have to investigate your answering ability to. What type of the deep rapid respiration is what we call the push. If you write Kushma, you are only talking about one aspect of the question. Combine all the three and give me the diagnosis. Metabolic emergency. Yes. Somebody says HHS. In HHS, do they have deep rapid respiration? Sarah, you're laughing at me. And Zuzu. Yeah, so HHS. This is a classical sign of what? DKA. DKA number 20, DKA. DKA. Okay, diabetic ketoacidosis. I've told you that the question will not bring ketones for you to be happy and pick it. You have to know the classical signs, okay? So Kushma. Okay. Good. Now, somebody asked one question. I did Oloko. Oloko, what was your question? Ask me your question. I answer it, then we go offline. Okay. So I'll give you this. Whilst Oloko is typing her question. Okay. Whilst this is this thing. I think I have to go for registration and give you a certificate because this one is a CPD, CPD point 8 or so. Can use it. So this is powers. Today you've done powers. When you see children, you will not fumble. Okay, these are all questions, scenarios. When we have not answered, when you get a slide, okay, make sure you sit down. Ask yourself: a child 2 years old brought to the ED with fever and poor feeding for 2 days. The child is lying motionless in the mother's arm and does not interact with you. So these are the assessments you did. You saw that the child was pale, weak, minimal spontaneous movement, respiratory rate is this, moderate subcostal retractions, heart rate is this, blood pressure is this, SAT is this, temperature is this, cap refill 4. So what three components of pediatric assessment triangle are you looking at here? What is your initial impression? What you, or I should keep the question so that tomorrow we use some 1 hour to finish or 2 hours. Or you want to get it? Because this one, anytime you do your PALS assessment, okay, when you come here and you do your PALS, these are the questions they will ask you. So each person and their question, okay. Me like this, my question was, they brought a patient from the house. He's at the OPD at the triage. When they called you to come and assess, okay, they gave you the science. So they will give you all the scenario. Then they will ask you, one person will, so one person you'll be standing there, they ask you, so like this condition, what is this? Then you answer. What is your initial impression? Then you say it. What should you assess first during ABCDE? Is this child stable or unstable or potentially critical? Okay. Last question. What intervention should be initiated immediately? Then you answer. Okay. Then another person. So you will pick your number. Maybe Sarah pick question number 2. So Sarah, when you pick, you'll bring your card. Question number 2. So Sarah's scenario is a 4 years old child presents with vomiting. She is sitting upright, watching cartoons, talking to her mother, and becomes irritated when you attempt to examine her. These are the vital signs you got. Okay. Now, Sarah's question number 1. They will read everything to you. Then, question number 1, how will you classify her appearance? What does the past part suggest? So, as assessment, what does it suggest? Does irritability towards healthcare staff necessarily indicate neurological deterioration? What additional assessment is required? So I'm giving you this slide, guys. Go home, sit down, and chill. Okay, and answer it. Thank you so much for today. Thank you, all of you. You've really done well. Let me give you plenty love and congratulations. Okay, congratulations. Right. I'll be starting work tomorrow again. Okay, so I need you. You might not be seeing me often, but if I get any spare 1 hour, 2 hours, you come and solve some question scenarios. Then we go our way. God bless you all. I love you. Bye bye. We did 2 hours, 47 minutes. Okay, so we try to manage our 3 hours time. Thank you so much, everyone. Bye bye.